This is Dr. Baliga here. This podcast is about SGLT transporters, that is sodium glucose transporters for the cardio-oncologist. Increased glucose uptake is a hallmark of cancer. The increased metabolic requirements of cancer cells have extensively been evaluated, and therapeutic strategies have been investigated to hinder tumor growth by interfering with glucose uptake and metabolism in cancer cells. The original observations by Otto Warburg that cancers utilize glucose anaerobically even in the presence of oxygen were consistent with increased requirements of glucose. The conversion of glucose to lactate yields only 2 moles of ATP per mole of glucose, whereas mitochondrial oxidative phosphorylation results in the net production of 30 moles of ATP per mole of glucose. Warburg concluded that a mitochondrial dysfunction was at the origin of cellular transformation, and to compensate for inefficient respiration, the transformed cancer cell needed to increase its glucose uptake and fermentation to sustain metabolic requirements of the cell. However, more recent observations have shown that mitochondrial activity is not impaired in cancer cells and is indeed required for neoplastic transformation. The reduced mitochondrial activity observed by Warburg in cancer cells could have been induced by the Crabtree effect, that is, high rates of glucose uptake and glycolysis in cancer cells can inhibit mitochondrial respiration, likely due to competition between glycolysis and oxidative phosphorylation for ADP and inorganic phosphate. Cancers upregulate both glycolysis and mitochondrial metabolism at the same time. There is metabolic heterogeneity in cancer cells, which allows coexistence of glycolytic and oxidative cells in different regions of the same tumor, and as a consequence of complex interplay between oncogenic alterations and microenvironmental factors, tumor heterogeneity is a significant obstacle to effective therapies, and there are 3 major sources of tumor heterogeneity: genetic, phenotypic, and microenvironmental. Genetic heterogeneity is a consequence of genomic instability, which over time causes divergence of subclonal populations of cancer cells. Phenotypic heterogeneity is probably determined by a complicated interplay between genetic, epigenetic, and environmental factors. Microenvironmental heterogeneity refers to the contribution of normal host cells and tissues that react to the neoplastic proliferation, affecting both positively and negatively the cancer process. These factors include blood vessels, fibroblasts, and connective tissue, and immune cells as well. Major mechanisms of metabolic cooperation or competition in the tumor microenvironment include lactate-fueled glycolysis, reverse Warburg effect, and immune metabolic competition. There is considerable heterogeneity of glucose transporters in cancer. There are 3 major classes of glucose transporters, particularly facilitative glucose transporters or GLUTs, the sodium glucose cotransporters SGLTs, and transporters of the sweet family. This latter class is largely represented in plants, and only one member is present in the human genome, SWEET1, and is likely involved in intestinal glucose absorption. Its involvement in cancer is currently unknown. The GLUT family, gene family name SGL2A, includes 14 known transporters. The transporters most frequently overexpressed in cancer are GLUT1 and GLUT3. The SGLT transporters, that is the sodium glucose transporters, belong to SCL5A family of sodium-driven solute carriers, which includes 12 transporters with different substrate specificities. In addition to SGLT1, SGLT2, SGLT4, and SGLT5, which are hexose transporters, and SGLT3, which is a glucose sensor. It includes transporters for myoinositol, monocarboxylates, iodide, multivitamin, and choline. Structurally, the best characterized are SGLT, SGLT1, and SGLT2. SGLT1 has been reported to be expressed in pancreatic, prostatic, ovarian, colorectal, and head and neck carcinomas. SGLT2 has been reported to be expressed in pancreatic, prostatic, and lung carcinomas, and in high-grade astrocytomas. The mechanism of upregulation of SGLT2 in cancer is unknown. However, a link between transporter expression and cellular differentiation has been recently reported in lung cancer. A paper in Sci Transl Med, published in November 2018. The lead author is Scafoglio, and the group is from UCLA. The title of the paper is Sodium Glucose Transporter-2, SGLT2, is a diagnostic and therapeutic target for early-stage adenocarcinoma of the lung. The authors discovered a potential marker, SGLT2, whose activity identified metabolically active lung pre-malignancy and early-stage lung adenocarcinoma. They found that SGLT2 is expressed early in lung tumorigenesis and is found specifically in pre-malignant lesions and well-differentiated adenocarcinomas. SGLT2 activity can be detected in vivo by PET with tracer methyl 4-deoxy 4-fluoroalpha-D-glucose pyranoside, that is Me4-FDG, which specifically detects SGLT activity using a combination of histochemistry and Me4-FDG PET. Scafoglio and authors identified a high expression and functional activity of SGLT2 in lung pre-malignancy and early-stage low-grade lung adenocarcinoma. Furthermore, using selective targeting of SGLT2 with FDA-approved small molecule inhibitors, the gliflozins, they showed greatly reduced tumor growth and prolonged survival in autochthonous mouse models and patient-derived xenografts of lung adenocarcinoma. They concluded that targeting SGLT2 in lung tumors may intercept lung cancer progression at early stages of development by pairing Me4-FDG PET imaging therapy using SGLT2 inhibitors. SGLT2 inhibitors have been also found to be beneficial in heart failure. The first cardiovascular clinical outcome trial of SGLT2 inhibitor therapy, the empagliflozin cardiovascular outcome trial in type 2 diabetes mellitus patient, EMPA-REG outcome, demonstrated an unexpected and substantial reduction in all-cause mortality, cardiovascular death, and heart failure hospitalizations among patients with type 2 diabetes. Significant reductions in heart failure hospitalizations were also demonstrated with SGLT2 inhibition with the SGLT2 inhibitor canagliflozin in the canagliflozin cardiovascular assessment study, and with dapagliflozin in the dapagliflozin effect on cardiovascular events trial, thus confirming EMPA-REG outcome findings. Therefore, sodium glucose transporter-2 inhibition is one of the most effective therapies to prevent heart failure in patients, particularly with type 2 diabetes. More recently, SGLT2 inhibitor dapagliflozin has demonstrated to reduce heart failure events, cardiovascular mortality, and all-cause mortality among patients with HFrEF, that is heart failure with reduced ejection fraction, irrespective of whether or not they had type 2 diabetes, in the dapagliflozin and prevention of adverse outcomes in heart failure, the DAPA heart failure trial. All these data argue that SGLT2 inhibitors are important in the management of heart failure with reduced ejection fraction, in addition to early stage lung cancer, as discussed earlier in the podcast. In fact, in a recent article in JAMA Cardiology titled Association of Optimal Implementation of Sodium Glucose Co-Transporter-2 Inhibitor Therapy with Outcome for Patients with Heart Failure, the authors Natl Bassi MD, Bobag Ziaeian MD, PhD, Clyde Yancey MD, and Greg C. Fonero MD, quantified the projected gains for deaths prevented or postponed with comprehensive implementation of SGLT2 inhibitor therapy for patients with systolic heart failure in the US. They found that of 3.1 million patients with systolic heart failure in the US, 69% were projected to be candidates for SGLT2 inhibitor therapy. Optimal implementation of SGLT2 inhibitor therapy, which they estimated would prevent up to 34,125 deaths per year. The range was from 21,840 to 49,140 deaths per year. A secondary analysis, excluding patients on the basis of NT-BNP and other trial entry criteria, would yield a potential benefit of 25,594 deaths per year prevented. The range was 16,380 to 36,855 deaths per year prevented. They concluded that there is a substantial number of deaths in the US that could be prevented by implementing SGLT2 inhibitor therapy. Given that SGLT2 inhibitor therapy is useful in heart failure and certain types of cancer, it raises the question whether SGLT2 inhibitor therapy can be used to prevent cardiotoxicity, particularly in patients who are pre-diabetic, insulin resistance, who are diabetic, high blood pressure, and dyslipidemia. Clinical trials to evaluate the role of SGLT2 inhibitor therapy to prevent chemotherapy-induced cardiotoxicity is the logical next step.